Welcome back to the True Sports Physical Therapy Podcast. Matteo Vertucci, I've been begging you to be on this pod for years now. I'm really happy to have you. Thanks for making time in your insane busy schedule. Yeah. Okay, so Matteo, you are a wizard with soccer players. You're a wizard with words. And you're a wizard specifically as it pertains to hip, groin, core injuries in soccer players. So that's what I want to dive into today. Just give me a little bit of your backstory, because I think it's fascinating. How you came to this country, how you came to True Sports, and what it is about soccer players that you absolutely love rehabbing.
So, I grew up in Rome, Italy, and I lived there for 16 years. Played soccer all throughout my life. Decided to come to the States back in 2008, and I played. I got recruited to play to IMG in Florida, IMG Academies, where the US based camp is. Played there 2 years, finished high school there, and was planning to go back to Italy. But then I got scholarship to go play Division I soccer. I got a full ride, and I was like, I still wanted to go back, but my parents were convincing enough to make the decision to go to college in America, play soccer, get my studies in, and graduated from 2013. Took a year sabbatical to decide. I knew I was going to go in physical therapy, but...
Did you think you were going to play? Did you want to play pro?
Yes. I mean, I had the opportunity when I was 14 and playing for the youth team of Rome. I was practicing with the first team, practicing with players that won the World Cup, but it was at a crucial stage of my career because I started to develop athletic growing pain.
Interesting.
And I was pushing through it, injection after injection, treatment, and so I just kept pushing through it to the point I couldn't even lift my legs, knees, just nothing really. And I was doing that for 6 months with injections as well. And to the point I had to take a break. I didn't want to get surgery. And then I had to stay out for 7 months. And that...
You missed your window. Okay.
Yes,
so you missed your window to play pro there, but then you get back on the pitch and you're able to get a scholarship both to IMG and then eventually to Towson.
Yes.
Okay. Looking back now, what do you think the diagnosis was then?
To tell you the truth, I still don't know. I think it was more inguinal related growing pain because I was having pain with coughing, sneezing, just lifting the leg. I did MRIs. I know I had a labral tear and a cam impingement, cam lesion.
So were they talking about fixing that? Or were they talking about doing inguinal hernia surgery?
Yes, they were thinking, well, they weren't jumping into the conclusion of getting surgery. They were working more on the rehab side of things. And back then it was just relative rest and passive modalities. I went to chiropractors, to craniosacral therapists, to PTs as well. And that's where I started working with this very awesome PT. And that's where I was like, oh, in case my soccer career doesn't go the way I wanted, because that was my dream from day one. This is what I want to do, right? I want to help athletes navigate through injuries, especially in these moments like I had to suffer, and I still kind of dream about, you know, since I have friends playing in the top division where, I think I was better.
You think you could have played? Of course you think you're better.
I think I was better.
That much I know about you. You think you're better.
I think I was better.
And you probably were. So if you were your physio then, knowing what you know now, what would you have treated?
Well, I would have definitely used more exercise-based interventions. Like I said, I didn't do much of any sort of exercise. I remember like it was yesterday. Didn't do much exercise. It was mostly stretching, passive modalities from tachytherapy to laser to shockwave to chiropractors.
Did it help, or was it just time?
It helped. But now going back to research nowadays, I look at it, I was like, maybe it was more a placebo effect, especially with the craniosacral.
Yeah, there's no way in hell that was helping you.
But it helped. I mean, also relative rest. I mean, regardless, I was out for 6 months, so
You just got better.
It just got better. I mean, I still currently have some experience of that growing pain, especially when I play or when I work on my sprinting mechanics.
And you had it in college? You fought this all the way through college?
Yeah.
Okay, so walk me through now. What specific biomechanical factors do you think contribute to this hip, groin, let's call it lower quadrant pain that you see multiple times a day while you're treating?
Yeah, so athletic groin pain is more of an umbrella term that just covers structures that are overloaded of the anterior hip and pelvis. There's many sources of discomfort, sources of pain. We don't want to get stuck too much on the source of the pain. We do want to reproduce and kind of like have a comparable sign, reproduce these symptoms. But at the same time, it's like, why are these athletes, why did I start to develop this sort of problem? But it's very common in field athletes like soccer, ice hockey.
Why?
Because of the nature of the sport, like sprinting, kicking, changes of direction, maneuvers. Those are all contributing factors to develop athletic groin pain. But again, there's specific biomechanical aspects that fall into that category, which is, according to a research from Alison Grimaldi, which is a very expert.
From what country is Alison Grimaldi?
I think she's American.
But originally... she doesn't sound Israeli.
Grimaldi sounds Italian, but I very focus a lot of the work on Alison Grimaldi and Enda King. They're my mentors. I don't know them personally, but
that's where you go.
Them.
Okay,
that's where I go. When I read their research, I read their books, take their online courses. But it shows that anterior pelvic tilt has a direct relationship to hip internal rotation loss. So for every 10 degrees of anterior pelvic tilt, there's a 5 degrees of loss of hip internal rotation.
Tell me if you notice this, because dealing with the population that you and I deal with at True Sports, elite level athletes, they're fast as hell, super springy. 9 out of 10 of these guys walk into our clinic and they're sitting in this tremendous anterior pelvic tilt. So I always wonder, is it the anterior pelvic tilt that somehow makes them more explosive and therefore athletically successful?
Could be.
Why?
Could be, but at the same time also predisposes them to fall into that position. And then, like I said, with the correlation to loss of hip internal rotation, especially with this change of direction maneuvers, if they don't have good trunk control over the stance leg when redirecting from a deceleration standpoint to an acceleration standpoint in the direction of intent, they can encompass these type of issues, especially if they fall into the biomechanical factors of hip adduction, knee valgus, foot pronation, ankle plantar flexions, especially with these changes of direction maneuver.
Which shows up a ton in soccer, right?
But one of the main contributing factors, and I feel like I've been focusing a lot and switching also my mindset, is also that control of hip extension. Like I said, according to some research from Enda and Alison Grimaldi, shows that for every 2 degrees of hip extension, there's a 20% more anterior compressive and tensile loading along that iliopsoas stand, and that control that anterior translation of the head of the femur provides that restriction. We know that iliopsoas has attachments to the capsule via the iliocapsularis, so it puts a little bit more demand. So walking, running, in that walking and running state where you go from end stage stance phase, toe off, and propulsion to the swing phase, that's where the hip generates more because
it's going to tug on that hip flexor.
It's going to tug on that hip flexor, and there's many structure at the anterior pelvis. The hip, like I said, the iliopsoas controls humeral head translation. You can get some impingement from the iliopsoas standing on the head of the femur, on the labrum, also on the iliopectineal bursa. So again, it's hard to derive a specific diagnosis because all these pain provocation tests, and as I'll explain later, are all sensitive, but not specific to where the pain is coming from But the key thing is, yes, is identifying the source where the pain is coming from. But at the same time, we also have to determine, like from a functional standpoint assessment, why are they developing these symptoms? We go back to those biomechanical factors and see, okay, how they move from a compound, a functional movement, just like squatting, lunging, RDLs, and then see how they move from a linear mechanic, multidirectional standpoint as well.
Okay, so it could be a number of factors, iliopsoas, anterior hip capsule, that are or impingement, right, that are causing these symptoms. You care less about that and more about the functional limitations, which you're expecting to be hip extension, internal rotation?
Yeah, hip extension, hip external rotation. But like I said, it's very important for me also to, and for the athlete to know where that pain is coming from. So palpation is going to be key in this factor, especially to reproduce these symptoms. You can try to reproduce them with the pain provocation test, but like I said, like the adduction squeeze test from 0, 45, and 90 degrees, the crossover, but those tell me that patient hip and groin is irritated,
hurts, yeah,
but just doesn't tell me where that pain is coming from. Palpation gives me a little bit better idea, and usually I use a clock approach where I start at the pubic tubercle and then make my way toward the 12 o'clock mark where the rectus abdominis attaches.
Where's the pubic tubercle?
Pubic tubercle is right, like a little bit lateral to the pubic symphysis, which is kind of like center in the pelvis. You slightly move laterally, and normally it's pretty easy to find because I just lay the patient in supine, laying down, and just rest his leg on my leg and have him do gentle push into my hand, just an adduction, and that adductor longest tendon should pop up. And I kind of travel my way there, and that's my landmark. A little bit above, towards the 12 o'clock mark, I start to get a little bit more into the rectus sheath. A little bit lower, I go to the tendon of the adductor longus. If I go medially, at 3 o'clock, I hit pubic symphysis, which most patients also are irritable there, like the osteitis pubis type of diagnosis, and then make my way towards the 9 o'clock and palpate inguinal ligament, inguinal ring, have them cough, see if there's a true herniation of that, and then make my way back to the pubic tubercle.
Okay, that's... First of all, thanks for reviewing that anatomy, because that would have been lost on me, so I appreciate that. But why does it matter? I mean, you're going to look at functional limitations, right? So why does palpation and the exact offending structure matter to you?
It matters for me, and it matters for the athlete to know where the pain is coming from. But like I said, I'm not so focused on like the source of the pain. Yes, I want to identify where the pain is coming from. Sometimes it's hard. And sometimes we don't get a true accurate diagnosis. People can be asymptomatic when I palpate those regions, but most people are symptomatic just because it's a sensitive area. It's a very sensitive area that also at the beginning I wasn't really comfortable in palpating. But through experience, I started to, okay, this is an important part of the assessment, but also it's important for the athlete to feel these structures, and
because why? Because why? Is this like a mental health thing where it's like, okay, I know exactly what's wrong with me?
Yeah, but also for them to understand where it's coming from, and also understand what we're going to do about it. But mostly we're not going to be stuck just to, okay, this is the pain of the location, let's just focus on this. But why? The most important is why you're getting these symptoms, right? And then we go back to the biomechanical flexors. And there's three components when I think about athletic groin pain, but it's also, we can relate to other diagnoses like ACL, right? There's the biomechanics, the patient's anatomy, and the patient's, how do they move with this compound lifting, like it's a couple of movements, like squats, lunges, RDLs. The tissue capacity, and the planing training volume and load. Those are the three.
Those are the levers you're pulling.
Leverage, yes. And then based on those three, I kind of get an idea on how to tackle and individualize a program with athletic groin pain. Because again, people can have the same source of pain and same symptoms, but as we know, also with ACLs, not every patient is the same, despite they get the same surgical graft.
Yeah.
Not every patient is the same, so you have to individualize based on their needs.
Dude, that is an awesome approach. It's really eye-opening. So, okay, once you identify the structure, you explain it to them. Hopefully you take them over to a skeleton, you explain exactly what you think is wrong with them. Then you're going to explain what you're going to do about it, what they're going to do about it from a home exercise standpoint, or maybe it's a volume standpoint, how they're going to handle those. Tell me about how you measure the biomechanical potential deficits.
Yes. So normally, like I said, this is day one. Let's say I have a patient coming in, I get their subjective report. I get, their playing, training volume, when did the symptoms started, did they have previous injuries or the same sort of injuries, and how did they manage it? After that, I go through an examination. I go through passive range of motion of the hip, active range of motion, and the key factor that I learned is also doing individual muscle testing, especially those dynamic hip stabilizers, the iliopsoas, the glute min, the external obliques, and let me think. There's another one, iliopsoas, glute min, external obliques. I'll get back to that.
Okay.
And deep external rotators. So I test those.
Okay, great. How do you test each one of those?
Those specifically, I test them in inner range because they have greater mechanical advantage to inner range, and I bring them to full hip flexion.
Say that again. To what range?
Inner range.
End
range.
Okay,
inner range, end range. For example, iliopsoas, I bring them all the way, depending, because some people can be provocative in those tests. So I get an idea. Some people have the tendency to veer off away and go in a little bit of hip external rotation versus neutral. I get them in those positions and test them, especially in a range with these deep hip stabilizing muscles, because these are going to control, the joint, especially anteriorly, laterally, and in transverse plane as well.
So you put them supine, you have them come into end range hip flexion, let's say.
Hip flexion. So I see what they have actively, and then I start, if the end range motion there, I see if I can bring them into more hip flexion. And normally I put my hand on the ASS to see when that pelvis is going to start to rotate. Get them there if they can attain it actively, and then test them into the inner range. Same thing with glute min. I put them more in sideline and have them do a straight leg hip abduction. I want to see first, their ability to get up. And most of the tendencies I see is they start to veer up a little bit into hip flexion, recruiting more of those superficial torque-producing muscles, like the TFL. I cue them, I line them straight line, from ankle to hip to shoulder to ear.
And that's looking mid or min?
Min.
Okay.
And then I see how much, you're going to get also some glute mid as well with that hip abduction. But then I see what they have actively, and then I get them into inner range, end range, and it's very difficult for them to maintain that position. Not many people can attain that position, but let's think about the glute min being the supraspinatus of the shoulder, providing that dynamic stability into active hip shoulder abduction. What are the role of the rotator cuffs, right? The rotator cuffs have to dynamically stabilize the shoulder through whole ranges, and then you have the torque-producing muscles to produce force, just like in the hip and pelvis is going to be the rectus abdominis, the rectus femoris, the TFL, the hamstrings, the glute max. And mostly there's like a loss of balance between, in this athletic growing pain population, loss of balance between the dynamic hip stabilizers and the torque producing muscles. So then I start assessing those initially, day one, and then I transition to that functional movement assessment from squatting. And normally I use dowel overhead to also see the thoracolumbar control. Then I take away the dowel, go from just a regular squat to a single leg squat, and just get an idea how these people move. Especially with single leg squat, with single leg drills, you can see very much differences as well as RDLs. Do they start to rotate at the hip because they lack a little bit dynamic hip control in that stance leg, and split squat as well. Those are the compound functional assessments I do.
Okay, hold on. Let me back you up a little bit because you hit glute you hit rectus, hip flexion, iliopsoas. Okay. And then you mentioned external oblique.
External obliques and the deep hip external rotators. So the deep hip external rotators, when I go and perform my pain provocation tests from a fader, flexion, adduction, internal rotation, see if they have a bony block, I get them, and I always standardize this to 90 degrees. I see what's their available active external rotation in the 90-degree angle, get them passively, and then, okay, can you resist?
Can you test? Okay.
Can I resist these motions?
How do you look at external oblique?
Normally, like that's a little bit harder to test. Normally, I do a Pallof press, or just like a side plank, but mostly Pallof press because it has that control on the.
Yep.
It's hard to test individually.
Okay.
But normally, I just have them do a Pallof press and see from one side to the other, because again, those muscles function also unilaterally. Do they have any difference in that control and just an isometric? How
do you see, I feel like there's so many ways to cheat a Pallof press, right? So how do you differentiate side to side a strength difference of some sort?
Well, it's with a Pallof press, I make them aware of that. I get them into athletic stance, a pelvic tilt, and the pelvic tilt, that's mostly how I initiate my rehab process, whether it's like adolescent athlete or a professional athlete. I want to see that lumbopelvic association and dissociation. Can they differentiate movements between lumbar spine and pelvis? That's where I always start with.
How do you do that? Standing or?
No, in hook line position, knees bent. I guide them through that motion, anterior pelvic tilt, posterior pelvic tilt, and then have them breathe and brace and control from the rib flaring aspect as well. And normally my cue that has been working a lot with me is pretend if somebody's about to punch you in the stomach, what do you do?
Yeah.
And most of the people start bracing.
Yep.
And then, okay, from a manual standpoint, I start to palpate. Okay, do you feel how you engage? And then anterior pelvic tilt, they start to lose that intra-abdominal pressure. They start to flare up a little bit the ridges from the motion.
Yeah.
I have them go back in, breathe out, exhale through that pelvic tilt, posterior pelvic tilt, neutralize the spine, brace, and try to keep those ribs down without flaring while breathing. And that's where I usually start. Then I kind of guide them through in prone. I start to, when I test for a hip extension, active and passive range of motion, I have them go, okay, let me see you lift the leg up from the table, straight leg up, and see what they do. And most people start to go past that hip extension till pelvis starts to tilt.
Yeah.
And the lumbar spine starts to extend. I was like, okay, so now, like, you feel this is, you feel in the glute or in the back. And it's important for me and for them also from a proprioceptive and kinesthetic awareness, to know how it feels, right? And that's where I start. Glute block, I say hip extension, engage that glute, that's end range motion. Past that, you start to get a little bit into the lumbar spine. So initial treatment when I assess these athletes is, whether it's professional, whether it's a novice, I always start with those. And that's gonna be foundation for the homework.
Yeah, okay, I love that. Now, when you mentioned that they'll commonly have a deficit of hip extension, right? You see that more actively and more passively?
Most people that have those issues with the front, they have an excess of hip extension, especially girls.
Too much hip extension.
Too much hip extension.
So what do you do?
True Sports Physical Therapy is growing like wildfire. We have 14 locations, soon to be more. We are throughout the state of Maryland. We're in Pennsylvania, in Lebanon and York, Pennsylvania, as well as in Delaware, in Newark and Wilmington, Delaware. Like I said, so many more practices to come, and we always need outstanding sports physical therapists. Our treatment style is unique. We are one-on-one with your athlete for 45 minutes every single session. You do the entire treatment, you do the entire evaluation, and they are in state-of-the-art facilities where you have room to run, throw, and jump, and really get your athlete all the way back to on the field and better and stronger than they were. We also have outstanding salaries, comp structures, bonus abilities, 401ks, as well as a very strong continuing education offering, including in-house continuing education. And we're looking for you. Now is the time, as we are growing like crazy. Just shoot your resume over to Yoni, YONI, at True Sports PT, or shoot us a DM and we will hit you back. We will get you in for our unique, tried and true interview process and really make a determination that this is the right place for you to grow your career and get your athletes better than ever. We can't wait to hear from you.
So we start with the neuromotor control. Like, for example, a great exercise intervention is a split squat or a rear forward elevated split squat. How can they control that hip extension, right? Because then it's going to translate, and we can go also to step ups, and then it's going to translate to the linear mechanics, the running mechanics. And once they get to that stage, okay, let me see how you run sprint. Probably have you start with a sumac sprint and see what kind of mechanics you have. If they have that backside mechanics, especially
where they're living in hip extension.
And then they're like not driving the hip into flexion and just straighting that back leg and kind of like almost like doing a butt kick. How much stress does it put to that anterior hip? So reteaching those fundamental movements is going to be.
So do you walk that makes total sense. Do you walk them, or does it start with a bridge from a supine position, and how well or do they actually use their glute to get to that hip extension?
Yes, I usually start with the bridges or like hip thrusts, and depending on how provocative they are, I do a double leg bridge with a ball squeeze, especially if they're very irritable, especially with the pain provocation test. Just to kind of create a co-contraction along that anterior hip and pelvis, because when we do the pain provocation test or the crossover test, for example.
Describe a crossover test for me.
Crossover test is like a Thomas test. Mm-hmm. It's a Thomas test. You put them in a Thomas test position, and basically there is going to give me a lot of just to put in my bucket to kind of rehab. First of all, do they have their thigh gonna sit completely down on the plinth? Okay. Making sure that they keep their back flat and not collapse into anterior pelvic tilt.
Now, if it doesn't, are you thinking they have a tightness anteriorly?
Yes, I can differentiate between iliopsoas and rectus femoris, but also what I see is how the leg is resting. Most of them kind of veer off to that hip abduction, and then I get an idea. Normally, I have them resist a hip flexion moment, and most of the times they're going to have pain to the contralateral hip. Sometimes, if very provocative, they can have it on both sides because of the line of pull of those rectus sheath and adductor longus that cross over at the pubic symphysis. So there's fascial connection. That's why there's getting a referral pain to the contralateral side. And then I see how much passively they can get into that hip abduction.
Like towards neutral.
Towards neutral, and if they're comfortable in that position as well.
Okay, and so if they're not, are you thinking it is a passive tightness anteriorly that's pulling them into abduction?
Yes, and then I assess also like for tissue tonicity, because it could be that they're using those torque-producing muscles as a way to stabilize that joint, not just to produce force, but also to stabilize the joint. That's why when I go through those dynamic hip stabilizing testing into end range with the hip flexion, external rotation, and the glute min individualized, then I can really see the true difference and just starts to put ideas on how my interventions are going to be for the specific.
Okay, so if they have a passive tightness, or by the way, even if it's a tone issue where they're using too many of these muscles and that muscle is staying contracted, are you then, tell me about what you prescribe to them?
So I would from that Thomas step position, I will see, okay, let's go into a split squat. And let's see how you do a split squat. And then I intervene with my cueing. Normally, I want to keep a 90-degree angle, just with the knee falling right underneath the hip, upright torso. Most of the times, you're going to see them kind of translating forward.
Get away from it.
Get away from it. But technically, I used to do lots of, the hip is tight, let's stretch it out. But sometimes going back to that hip extension aspect of things,
Yep.
isn't it? And then it puts into my brain, it's like, isn't this making it worse?
Mm-hmm.
Right? So I try to do teach them fundamental movement pattern with proper mechanics and hammer it like that, with avoiding the stretching aspect. And some people need it, yes, but I just teach them proper way of performing a split squat with proper mechanics, and it's gonna tackle the issue.
And so you feel like that's a better intervention. Is there ever a time that you go to like a couch stretch or a hip flexor stretch?
Occasionally, yes, but with people that have extensive amount of hip extension,
That would be counterintuitive.
Because many people that report that tightness on the front of the hip, it's not mostly the tightness. Like I said, it's lots of specific sources of pain, but at the same time, you don't want to overstretch these tissues, especially knowing the mechanics of how much hip extension can load that anterior hip pelvis. Sometimes I do with people that are extremely, extremely tight, but the people that have, especially the girls that are rehab with a hepatic bone pain, they have extensive amount of hip extension, especially the ones that also do dancing in combination with soccer.
Interesting. They just have too much motion. It's a hypermobility issue.
And how we control that motion is going to be key. And split squats, Bulgarian split squats are going to be my go-to exercise.
So I'll tell you, early on, I know I would see these hips. I didn't do as thorough a job as you do of differentiating between, is it a loss of hip extension, or is it poor control of hip extension? And so I would stretch the hell out of them.
Mm-hmm.
And a lot of these athletes would go forward, and let's say you get an MRI, it's going to show a labral tear, and docs will go in and fix it. And 9 out of 10 of these girls that were getting these surgeries would fail that intervention because the issue was a hypermobility issue versus a hypomobility. So you've done a great job of differentiating between hyper versus hypo, and whether it's their control, right? And educating them, okay, you have the motion, you're just not using the motion. I guess what are some of the interventions that you would do for the deep rotators to help stabilize that hypermobile hip, since they're not a candidate for surgery?
Normally, I start with I don't know if you're familiar with this exercise called a crab banded squat.
I'm going to go with no. What does it look like?
Well, just you kind of hold on the rack or some for support. You get an athletic stance, maybe a little bit deeper, and bend around your knees. And normally I do it without shoes because I want them to basically do hip abduction and external rotation by grounding their big toe on the ground.
Making sure they're not falling onto the blades.
Yeah, exactly. And supinate and really feel it in that posterior lateral glute. Another way I do it is in a half lunge position and put a super bend around the outer knee. So the knee...
The back knee?
No,
front knee.
So front knee. So you're going to, if I'm looking for you like this, I put a bend on the right knee. I go in a split stance with my right knee onto a foam pad.
Yep.
And then work on that, driving into external rotation with that bend, still keeping that big toe.
Band is pulling medially, you're pulling into external rotation.
Bell is pulling, yes.
Okay.
Yes, bell is pulling immediately, yes.
Okay, now, do you ever do that on the... Because my thought is, they're sitting in hip flexion there, and so maybe that's a deficit, their ability to control that. What about the rear leg? You ever put affected limb in the back?
Yeah, I do it with both both legs. And I get them in that position, okay. Upright posture, pelvic tuck, okay. And just stabilize. Sometimes I give them assistance, through the rack or to a dowel, and try to get that motion without swaying too much and keep good control. And normally I do that with what's it called?
Just say it in Italian.
No, I do that with a dowel or with a rack at this disposal. Or another way I intervene with that is lay them down in hip abduction, lay them down in sideline.
Yep.
Get their hip, see what's their active range of hip abduction. Bias a little bit that external rotation of the foot. Get them into inner range. and hold that position with my backhand just supporting that leg.
Yeah, and hold it there.
that position, and it's tremendous.
It's brutal.
Tremendously humbling exercise.
I'm sure. Okay, so those are some of the ways that you're hitting a hypermobile joint, right? If they are hypo, that they truly don't have that extension, that's when you're going towards stretching or passive stretching. Okay, then talk to me about the role of adductors in this population.
Yeah, adductor strength is one of the main factors, like adductor deficit in strength is one of the main factors that leads to athletic groin pain. It's a fact. Its research shows it. Now, with the access of True Sports giving us a handheld dynamometer, I think it's Mark 10, I believe, we have the ability to measure that individual muscle group and compare it to the hip abductors and measure the peak torque force production of those adductors. And normally I calibrate it into newtons. I get their moment arm from the greater trochanter to 2 centimeters above the malleolus, and get their body weight in kilos, divide moment arm by kilos times the newtons, and I get that peak torque force production. Numbers that I'm looking for is I started investing. I did it a lot with people, and I thought 1.5 was the norm, also according to the data, 1.5 millimeters per kilo.
Yep.
Now I start to veer off more towards the 2.0.
That's where you want them. Okay, and then so that's fascinating. So, and to test that, you have them in sideline.
I have them in supine with this one.
You have them in supine, and they're just pulling into adduction.
Pulling into the adduction, holding opposite knee is bent, holding on to the plinth, and standardize it like that.
And what angle of hip abduction?
Neutral. I do it in neutral, and I do 3 tests, make sure also that they don't compensate and cheat by rotating the pelvis, flaying the ribs. And normally I do a test of 3 on each leg with a 30-second break. And normally it's a make test. So I have them push them. Break test, yes, I can do. And I try to standardize this. So I test them all in the same position. Eventually, I probably also get a little bit some data.
And you're holding the handheld.
Yeah, handheld stabilizing, get good stabilization, because some people can really push
kick
you
across
over,
the room,
especially with hip flexion.
Yeah.
And then I perform a make test. I have them push into me. Break test I would do probably in sideline. I have attempted to it, but some people it's hard to kind of get them in that position.
Yep. So you have that standardized. Then what are you prescribing to start with for adductor strengthening at home and then in the clinic?
Yes, I always see, okay, let's try a Copenhagen.
Yeah.
Let's see. And many people never done that before. Yep. And for people that are introduced to a Copenhagen, it's not the
also
easiest.
Humbling. Yeah.
It's not the easiest exercise. I demonstrated it myself, and now I'm a master of it.
Master.
Master.
Self-described master.
At Copenhagen, yes.
Yes.
I demonstrated. I have
Bent
them
knee.
Start long lever.
Why do you start long lever?
I want to see what the hardest thing. If they're able to do the hardest thing. If they're not, okay, I go to bent knee. Okay. If not, I just go back on the plinth. Sometimes I discovered this new exercise where like you go in a side plank, you put a Swiss ball in between the legs and you just squeeze it, or going back to the table and just do like a ball squeeze, especially with those people that are very irritable.
Yeah.
Just on a ball squeeze isometric.
Do you ever do like a straight leg raise horizontal adduction?
I do.
Okay.
Sometimes, yes. Not so much, but that could be a very easy way for an athlete to do.
To start with, okay.
Yeah, or to do at home as well.
And then do you always start isometric? I guess like with a ball squeeze, like walk me through how you go from eccentric or isometric, eccentric, concentric. How do you think through those?
So there's also a linear progression that I follow with the athletic groin pain patient, right? There is anatomy of the individual patient. There's the intersegmental control area where we look at those compound movements, compound strength, motor control, and then transition to strength and power.
Yep.
And then we can start to load them up, but also we have to think about that power aspect of things, right? And that's the tissue capacity into the triangle. That's why doing counter movement jumps, drop jump is going to give me some objective data on the reactive strength and explosive strength, because it's going to transfer to those changes of direction.
Okay, so no question, and I love that. I feel like that's down the road though, right? So early on, how much are you thinking through what type of contraction they're performing?
I normally start with isometrics. Isometric or just active, like isometric, like double leg glute bridge with a ball squeeze. Keep it very simple.
Yep.
Keep it very simple. Or just like a wall squat with a ball squeeze. Or just, I veered off a little bit from the clamshell standpoint of things. Band walks, that's not more of an isometric, but it still provides, or crab banded squats for those hip dip rotators, planks. Forearm planks, side planks, those are mostly the interventions I hammer home day one.
Okay, so that sounds very isometric based, right?
Yeah, yes.
And then stage 2 would be
more those dynamic type of movements, that motor control, that segmental control. Squatting, maybe start with goblets, just to kind of keep an upright posture, good torso position. Start at the bench. Then eventually we can go and play around with those deeper ranges of position. Then do some axial loading. If they're getting comfortable with the goblets, I go through some axial loading, and then I start to do RDLs, split squats, trap bar, all of those things from a strength perspective. And then you can play with the rate of force development, the speed aspect.
How rapidly they're moving. Okay.
You can do it.
Now, what about hip flexor strengthening?
So that's the biggest thing. And I keep saying to my mind, do I train hip flexor? Do I isolate hip flexor or not? One of the main hip flexor exercises I start with is that at the wall, 90-90 position, hip flexion lift off to inner range and hold isometric. That's what I start with. Or if they have good enough balance, and single leg control, I have them do a knee hug all the way to end range without going into lumbar
standing.
Okay. If they have good control, or maybe I place them next to the wall. I go to inner range hip flexion, and then I tell them slowly let go of that. Now, then you start to pay attention, are they able to maintain that inner range? But most likely, you're going to see that drop. So I make them aware of it. And maybe then I go back towards the 90-90 wall position, or simply I start with a hip flexion isometric and hook line position. Knee bent, drive one knee to your hip, apply pressure, and you're going to get also a little bit those abdominals involved into it.
And then do you progress towards eccentric motions there?
So sometimes I do I progress to eccentric motion, like for example a dead bug. I do them sometimes when I do a progression from a level floor. I put them on a bench and try to control past that bench, past that neutral bench, and just control. And sometimes I also have them hold a medicine ball. For people that have very good control, they can kind of time that shoulder flexion in combination with that hip extension with a dead bug, and make sure that they really feel that interconnection between the segments. If not, I just start with just level drop, eccentric. And the dead bug is going to be one of my fundamental exercises.
Okay, that makes a lot of sense. Now, how do you, if you do you differentiate your intervention based upon the level of athlete? Like, is this the same prescription you're prescribing to a pro, an MLS guy, as it is to college, as it is to high school?
I would start with the same approach. Of course, professional athletes, they have much more experience into the lifting aspect of things, much more load capacity compared to an adolescent novice athlete that never lifted a weight. But I start with the same approach. I see how they move. I wouldn't change much, and keep it simple. See how they move, keep it standardized, and I will progress them a little bit quicker just because they have more motor control compared to the adolescent athlete that doesn't really know how to move. Yes, some people do, but some people.
But it's just gauging what the athlete is able to do, what their motor age is, essentially. Okay, so that makes a lot of sense. What do you think the number one mistake therapists make when treating hip pain?
For me, it's reassessing. That's one of the key markers, right? Normally, with every patient, athletic growing patient, and it's a lot of work though. It's text me. I give him my personal number.
You're crazy with that, dude.
I know that's why I'm a little bit late with the texting.
Yeah,
it's like I get 40 texts a day. But how do you feel the next morning? Okay, is the hip more irritable? Okay, and that gives me an idea. Okay, maybe next session we have to back things down, or it's good, feels better. Now we start to progress a little because there's key performance indicators that I wanna achieve with this transition from intersegmental control to power and going back into the sprinting linear before multi-direction, change your direction, and sport-specific training. I always go back to those pain provocation tests. If they're irritable, okay, more than usual, okay, I just have to take a humbling aspect. Maybe
we did too much.
They exceeded their tissue capacity or loading capacity. Let me take a step back. So it's always the key thing for me that helps a lot, and also seeing success in these patients is the communication, is that giving them like a way that always come back to me, even via text, give me feedback on how they feel, and then I can kind of plan what I want to do next session and give them a much better day. Because sometimes people forget. If I see them 3 days later, they're like, "How did you feel the next day?" I was like, I don't remember.
I don't know.
I don't remember, but I give my personal tell because that's exactly how I wanted to be treated. And I always put myself, and that's for me, like why I consider myself, a good PT, because I always try to put myself in the patient's shoes, see where they're coming from, see their frustrations, understand them, because I've been there as well. And it just makes me think about me when I was their age and how I wanted to be treated. So I treat every patient, I try to treat every single patient the same way. But
you sound like a young Tim Stone who always said, no one cares how much you know until they know how much you care. And it's clear that you care and you go above and beyond with that level of care. So that is awesome advice. Talk to me about the strength and conditioning world. How do you prefer to collaborate with strength and conditioning coaches as it pertains specifically to this population? Hey guys, quick pause and a quick shout out to this new masterclass that we just launched here at True Sports Physical Therapy. Myself and Dr. Tim Stone put together a masterclass of ACL rehab, and we call it From Table to Turf. And the reason we call it that is because it's going to teach you exactly how to get your athlete all the way from post-op day one with the nitty-gritty of regaining all of that range of motion, with the tips and the tricks that we use here at True Sports Physical Therapy that gets our athletes better, faster, and stronger. And that's early. And then how do you progress that athlete all the way onto the field with a ball in their foot or a stick in their hand or whatever their sport is, and teach them how to accelerate, how to decel, how to change direction, and all the mechanics that go in there. What drills do we use to get our athletes exactly where they need to be back on the field and even better than before injury? And I want you to sign up for that class. Now, you can find it on our website. You can shoot us a direct message and just say, hey, send me the course. It's right now on sale, so make sure you sign up now. It is fully accredited to get you all of your continuing education hours. Sign up for the True Sports Masterclass ACL, From Table to Turf. Thanks, guys.
Yeah, so normally I would send them to our strength and conditioning coaches just because we're in the same clinic for True Sports and Sweat Performance. I, of course, make them aware of where we at with the rehab, what we've been working, like what we've been rehabbing for, and what stage they are. And then most of the times, we're always there, so we can communicate directly with them. Sometimes I'm working during the same time they come and work out. So I get an idea. And then, like, okay, I'm with the patient, but I was like, okay, I see him. I see my patient working with Danny or Courtney, the strength and conditioning coaches, and I'm like, stop by after and just let me know how you felt,
Yep.
how they felt. What did you do? Because I cannot observe exactly what they
Yep.
did, and report to me. Same
Yeah.
thing. So because understanding their playing and training volume, if they're a multi-sport athlete, that's the main thing. Like I start with the subjective, like what's your training schedule?
Yeah.
Right? How many times you practice a week? How many games you practice? Do you play other sports? Do you do strength and conditioning? Most of these kids do a lot.
Yep. Yep.
Do a lot, but at the same time, like they do mostly different sports, and they don't get exposed to the strength and conditioning aspect of things. And for me, it's fundamental that even in season they get some loading aspects so they can kind of withstand those sport demands.
I love that, and I think that that's totally nuanced, right?
Mm-hmm.
It's understanding that sometimes increasing their load, as long as it's done judiciously, will help them kind of get back quicker, but also be able to withstand the rigors of their training schedule. So I think that's also something really important to the young therapists out there that are listening, is understanding the demand that is out there, and how do you pull levers to either pull them back or keep them strong and get them stronger even in season.
Yeah.
I think that's a mistake that a lot of coaches and PTs make, is either shutting them down completely when not needed necessarily, or just understanding their overall load. So I think there's a tremendous amount of value there. Okay, let's go to return to sport. How does an athlete know when they're ready to get back on the pitch and actually compete? How do you walk them through that?
So I explained it from day one. There's these like criteria that we have to, these stages that we have to pass. Understanding their anatomy, their biomechanics, transferring to it that intersegmental motor control, strength and power aspect. We get objective data to individual muscle with the held dynamometer, measure the reactive strength, explosive strength, get baseline on that and program for that, transition to linear mechanics, multi-directional change of sport direction, and sport-specific movements. Now there's different in between sections from intersegmental control to linear mechanics. They have to have a pain-free crossover sign. Okay. Based on that, okay, we go through the running mechanics, sprinting mechanics. Then we transition to those multi-directional changes of direction. They have to have symmetrical hip internal rotation or to whatever it's available, pain-free adduction squeeze test, and asymptomatic with linear sprinting. Then we go from planned change of direction to chaotic change of direction, and then we go to sport-specific tests. Now, sport-specific movements like kicking, and I always start with wall ball, but most of the times me coaching at Pipeline for 13 years, I have access to fields, and normally I bring them out to the field, test them, of course, depending on their stage of rehab, start them individually, then create a group, organize a group session to expose them to more those specific sport demands. And then probably like 1-2 weeks, and then taper them back in to practices. But again, key marker is communicate. How do you feel next day? And then I communicate with the coaches, since I see them most of the times, especially with Pipeline kids. I'm like, I give them the rundown. I usually call them because texting it can be a little bit misguiding.
It's a heavy lift, dude.
It's a lot.
But I think it's necessary, right? Otherwise, you're shooting in the dark. You don't really know how your athlete is responding. You don't actually know their load, because a self-reported load is worthless. So being able to visualize them, being able to communicate with the coaches around them gives you a full picture. You have any examples of athletes that didn't? I mean, it sounds so easy the way you describe it. I mean, I know I just said it's hard. I know it's, but it sounds, I guess, without hurdles or without speed bumps, the way you're describing it. Give me an example of an athlete that you thought was ready to get back on the pitch. They passed all their tests with flying colors and they just weren't ready, and what it is you learned from that experience.
I have one specific case, and it's very, very frustrating. I started working with this high school sophomore, plays top ECNL, like top level club soccer with Pipeline, first team. McDonough, starting freshman, been experiencing hip apophysitis since November.
Yep.
Okay. Missed all the high school season.
That's you. That's a young Matteo.
Okay. I'm better now.
Yeah, obviously.
Yeah, but she missed all the high school season. I started seeing her in November. We ran through all the things I described.
Yep.
And the goal was to get her back to team training January 1st.
Yep.
With Pipeline before the demands of the season increase, because that's the stages that you want to be ready for, playoffs and all that going forward. I ran her to, like, we went to practice twice a week. Everything was going with flying colors. 2 weeks of practice, great. Then the training volume and training load started increase. We, I communicate with the coach and my boss as well.
Yeah.
And they were doing lots of conditioning, sprinting, everything, to the point that hip was getting irritated. I told taper back in.
Yep.
And 2 games on the weekends, plays 2 games, and then there's a setback. Okay. And then, we just come back in, reassess everything. I have her go to a doctor. I use my sources as well. I was like, okay, let's get an imaging. Let's get an opinion from a sports doctor. And send him there. Next day, was able to get in, imaging, it's the cam lesion, labral tear. There's a little bit of synovitis into the hip flexor. Okay, we take 3 weeks of deload, no training, go back in, same thing, go back to training, re-aggravates it, intra-articular hip injection, restart from 0, and now we're at the 8-week mark. After that, transitioning back to practice is going well so far. Fingers crossed, but that's one of the most frustrating.
What would you have done differently?
Quite frankly, from a rehab standpoint of things, I probably would have worked a little bit, get her a little bit of objective, because she's strong. I didn't measure the counter movement, jump, and explosive strength. I probably should have measured that early on and work on those changes of direction, maneuver, the ability to propel and accelerate, absorb and propel. Those are the things she needs. Sprinting mechanics, all those factors. And I'm putting more emphasis on now. And actually, I'm going to that speed clinic this weekend in Pittsburgh with sportsmen. And that's the area I want to get better at analyzing and prescribing and know how to coach.
Yeah, I love that.
Because that's, if I have to take it on, I take every time something on me, because I don't put too much on the patient. I do sometimes but I always reflect on myself first and what could I have done different. And that's what keeps me up at night, literally. After every day at work, I go back home and I was like, I did very good today. And I was like, today I was with this patient, I was like, I could have done better.
Could have done something different. But I think that means you care. And I think you keep learning on it. It's amazing to hear you speak on this stuff. It is so different than conversations we had 2-3 years ago, just what you've added to your arsenal. And there's plenty more to learn. There always will be. But I think that speaks a lot about you as a clinician. That's why you're on the True Sports Podcast. Okay, there's so much more I want to get into the hip, but I think you covered a ton, and that's been awesome. Let's go to the Cressay lightning round. You ready?
I don't know what that means.
Okay, fair answer. Here's what it means. I'm going to give you questions. You're going to respond rapidly. Okay?
Okay.
Rapidly.
Okay.
In English.
First answer.
Yes.
Okay.
First answer. First thought. The best soccer player in the world.
Currently?
Yes.
Currently, I always go with Ronaldo.
Okay. Ever?
No. The real Ronaldo, the Brazilian Ronaldo.
That guy's better than this one?
Better.
Why?
Better. It was something out of the norms. If he didn't have 3 ACL injuries, I mean, that guy was unstoppable.
Better than Messi, better than
personally-
Henri, better than
Ronaldo the Brazilian was the best thing I've witnessed watching, and I had the pleasure to meet.
Was he
my
nice to you?
Very nice. He spelled my name wrong with one T, but it's okay.
So do I.
And I have his jersey and his signature, and it's framed. That's my possession. That's like I would trade anything, but not that jersey and not that signature. It's been there since I was 10 years old.
The best.
That's my most important thing.
Okay.
Right there.
Let me ask you this. What's the hardest thing about not being an English native speaker?
I can get away with it. It's not like
I can
get away with it.
I don't know if that's the way you look or the way you talk.
No, I can get away with it. But I mean, I've been speaking English since I was little. My dad is from Texas.
Yeah, which is ridiculous.
As you can hear.
Yes, I can clearly. What language do you think in?
Italian.
What language do you dream in? Italian.
And count Italian. Yes, Italian.
Is that ever going to change?
I don't know. It hasn't changed in 15 years I lived in America. I dream.
How do you do that? I mean, do you feel like it slows you down?
No.
Is there ever a barrier of communication when you deal with other athletes?
No. Sometimes they don't understand me, but but they've learned some Italian in conjunction as well. But yes, I think in Italian. I don't know why, but it's kind of crazy.
Okay.
Definitely dream in Italian.
Okay. Who is the best soccer physical therapist in the world?
Soccer physical therapist. I mean, well, I aspire to be one.
Other than you, Matteo.
I aspire, but I always look up to this guy, Enda King. He works with everybody.
Say his name again.
Enda King. He
Where?
works from. He's a clinical director of this clinic in Dublin, and he works for Aspetar. And most of the top professional soccer players go to Aspetar. I mean, the facility there. I've never been, but I've looked on the internet,
and it's amazing.
Like outstanding. But I look up a lot to Guy, but also to my coworkers as well. And we have a really great team in the Timonio location. Look up to you.
Thanks, man.
Well, and
that's what I was getting at. That's what I was.
No, but I learn a lot from everybody. I'm very humble. I'm always willing to learn, and that's my motivation. I always think that somebody else, same thing, and that's the soccer in me. That when I wanted to become a professional player, I always put in extra work, and that same mentality, believe it or not, I transferred to my studies and to my profession. It wasn't that fun at first, to train soccer versus sitting down in the library and studying.
Yeah. But
that is the mentality I developed since a young age, playing the sport, competitive against myself. Even if I reach an objective, I'm never content. I always can do better, and I always can do more. And
where does that come from?
Me.
Did anyone model that for you growing up? Where did you see evidence of that?
I mean, my parents, yes, play an influence, but I'm different in terms of that. I have that dedication and passion and willingness always to get better at everything and never be happy with anything. And,
well, it shines through. When did you and how did you learn how to walk on your hands?
Walk on my handstands?
Yes. Handstand.
Probably 4 years ago.
How did you learn that?
Just playing around with my morning meditation at 4:30 in the morning.
Walking on your hands?
No, just going against a wall, putting some meditation music to help me relax as well, and try different things. And then I was like, oh, maybe this exercise could be very good for our patient. So it's just movement exploration. I got into that a lot, but it started when I was watching Conor McGregor train with this guy, Israeli.
You know.
Yeah. But I mean, I don't do that stuff in public. I like
Yeah.
walk on my hands and crawl.
That's not true. I've
Uh,
heard from other patients that you're walking on your hands in the gym.
Yes, a couple times.
Okay,
but
that's a couple more times than
But
me.
I don't start doing scorpion walks on top of stairs.
Not yet. You will. Maybe if
only-
you challenge yourself, Matteo.
No, but only at home.
Okay.
Not in, handstands in public, okay, but the other one.
Okay, last question. If you could never rehab another footballer in your life, what sport would you love to rehab?
Since I live in Maryland, lacrosse.
Has that shocked you?
I mean, at the beginning, yes, but it's probably the sport I like the most after soccer, lacrosse.
Can you play catch with a lacrosse stick?
I can try attempt. I can catch the ball. I don't know how to cradle it.
I
don't know why.
Can you throw a baseball?
I can throw, but probably after 10 pitches, my elbow starts to hurt. I work with a pitcher. I remember working with a pitcher, and we were practicing pitching, and I decided to catch.
Oh God, what did that look like? Is that why there's a hole in the wall?
No, we did it the opposite side towards the wall, and I caught it the wrong way. And the worst thing, I caught it not in the what's it called, the glove
Web.
The
glove compartment. I love that.
And just went through my hand. I was like, okay, we're just gonna put a foam roll here, aim to that.
Smart. That's very
But I
smart.
tried to throw a couple times, and after 5-6, my elbow
Hurts your elbow.
I was like,
Change that. You have enough injuries, Matteo. Matteo, you first of all, you did an awesome job with this pod. You told me a ton. You were insanely concise.
That's
Unbelievable. So thanks for doing it in English. I appreciate that greatly. Thanks for taking your patient care so seriously. That comes through with every sentence that you speak, that you just give a damn, more so than anyone else in the profession. So thanks for bringing that to work every day. You have been awesome. Tell the millions of sports PTs where they can find you.
They can find me on Instagram, football therapy, FUTBOL.
How else would we spell it?
Yeah, exactly.
Yeah.
The real football, the one that you play with the feet. And
Yes.
I want to reiterate that. Therapy. And yeah, that's my Instagram professional account.
Love
I'm
it.
trying to grow, but and put content for other people to see what I do. And if they want to contact me, they can DM me, and we can work together eventually. So,
I love it. I love it. Matteo, thank you for the knowledge. Thank you to everyone who is listening out here. Let us know how we did. You can always find us, True Sports PT, on Instagram. You've been a pleasure.
Thank you, Yoni.
Bye-bye.